Hello, everyone. I'm Laura Sparks, President of the Cooper Union for the Advancement of Science and Art, and it is my pleasure to welcome you this evening for our 2020 John J. Iselin Memorial Lecture. For 161 years, the Cooper Union has provided a forum for influential voices and everyday people to discuss and debate ideas, to foster creativity, and to address pressing issues of the day. And while we would traditionally hold this lecture from the stage of Cooper's historic Great Hall, we are delighted to be able to continue our programming to the public remotely. At a time when staying connected and engaging with what's happening in the world has never felt so important. It's such a pleasure to see you all here this evening. For those who might be joining us for the first time, the Cooper Union is among the nation's leading colleges for students pursuing degrees in architecture, art, and engineering. Tonight's endowed lecture is presented in memory of our institution's 10th president, John J. Iselin, celebrating his commitment to the benefit of society through greater public understanding of science, technology, and the arts. My deepest gratitude to Lee Iselin and the entire Iselin family for making this event possible. This lecture endowment has allowed us to host prominent activists, leaders, and scholars from across different fields, public health being just one of them. And we are so honored to have the opportunity to share that expertise and to generate dialogue around questions of urgent social concern. At the heart of Cooper's mission really is the idea that education is imperative to a well-functioning democracy. And with the complex challenges of COVID-19 radically transforming our world over the past year, we've seen just how crucial a role education and scientific literacy play, not only in promoting public health, but also in informing policy decisions and operational pivots, understanding health inequalities, and demanding action of our political leaders. At Cooper, one of the things we strive to cultivate in our students is a capacity to think and communicate beyond their discipline, to understand how to translate specialized knowledge into broader societal implications. Our featured speaker tonight is an incisive and illuminating writer whose career offers really a shining example of that. Ed Yong is a science journalist and staff member at The Atlantic, whose award-winning work has been celebrated for combining scientific depth with an accessible, inclusive, and an unceasingly curious approach to storytelling. Ed has been one of the most prolific reporters on the novel coronavirus, advocating awareness and helping us make sense of the disease and the impact on our lives. Incredibly, back in 2018, he penned an article for The Atlantic titled "The Next Plague is Coming, Is America Ready?" predicting the threat of a global pandemic 2 years before it hit and issuing a warning call for how unprepared we really were. From reporting on how COVID-19 exposed longstanding health disparities throughout the US to taking on the mask debate, Ed has offered careful, perceptive analysis of the health crisis as well as the governmental response to it. His writing offers clarity and astuteness at a time when uncertainty and misinformation has run rampant. Ed's writing has been featured in National Geographic, The New Yorker, Wired, Nature, New Scientist, and Scientific American, among others. He was recognized with the 2020 Victor Cohn Prize for Medical Science, reporting from the Council for the Advancement of Science Writing, and with the National Press Club Journalism Institute's 2020 Neil and Susan Sheehan Award for Investigative Journalism. He is the author of the New York Times bestselling book, I Contain Multitudes, and his TED Talk on mind-controlling parasites has been watched by more than 1.5 million people. We are so honored to have Ed Yong with us this evening. Following the lecture, Jennifer Weiser will be joining Ed for a brief discussion. Dr. Weiser is an assistant professor of chemical engineering at Cooper's Albert Nerken School of Engineering, where she researches drug delivery, wound healing, and developing polymeric biomaterials for medical applications. Since the fall of 2019, Dr. Weiser has collaborated with the Orthopedic Research Department of Mount Sinai to pursue the creation of injectable biomaterials for use as controlled drug delivery vehicles for biologic drugs to help in the repair of intervertebral discs in the spine. She received her Bachelor of Science in Chemical Engineering from Rensselaer Polytechnic Institute and her Master of Science and PhD in Biomedical Engineering from Cornell University. My thanks to both Ed and Jennifer for being here, and thanks to everyone for tuning in. Just two quick final notes before I hand it off. Closed captioning is available for this program, and if you have questions for our speakers, please submit them via the Q&A feature. Our speakers will address them after the discussion. Now it's my great pleasure to welcome Ed Yong.
Thank you so much for that kind introduction, and I'm really honored to be here today. So let me start by telling you a story from that 2018 piece that I reported about whether America was ready for the pandemic. So in 2018, I went to the University of Nebraska Medical Center in Omaha, and that was a crucial visit because more than almost any other institution in America, the UNMC had taken the threat of pandemics very seriously and prepared for such a possibility. And they had done that so ever since the first original SARS virus started sweeping the world in 2003. They recognized that emerging infections would be a growing part of our lives and that they needed preparations beyond what most hospitals were girded for. So the University of Nebraska Medical Center created the nation's largest biocontainment unit, which cared for airlifted Ebola patients in 2014 during the big West African outbreak. They created the nation's only federal quarantine facility. They created incredibly detailed pandemic plans, what to do with elective surgeries and organ transplants and every kind of patients and every part of the hospital in case a pandemic should happen. They trained, they drilled, they prepared. And there is a reason why many of the Americans who were airlifted from the Diamond Princess cruise ship this year in February with COVID-19 were sent to UNMC. As I said, arguably no hospital in the United States was better prepared for a pandemic. And so now what? Well, I talked to the team again 2 weeks ago, and they are struggling. Even this hospital, which had taken the threat seriously and was aware of what was happening, is besieged. An entire building at UNMC is now a COVID-19 tower with 10 separate COVID-19 units, each taking up a separate floor. One of those units is only for people to go and die. Of late, there have been days where the hospital has had between 45 and 60 fewer nurses than it needed. One of those nurses, who normally works in oncology, told me that even though death is no stranger to her and she is used to having to care for extremely sick people, she can barely comprehend the amount of death that she has had to see over the last few weeks. People at UNMC, infectious disease specialists and veterans who have been thinking about this for a long time and are not easily shaken, have said things to me like, we are on an absolutely catastrophic path, that we are watching a system breaking in front of us and are helpless to stop it, that people need to know the assumption that we will always have a hospital bed for them is a false one. And this same trend is happening to hospitals all across the country. America was once rated as the country best prepared for a pandemic, #1 in the world. And it has been utterly humbled by the SARS-CoV-2 coronavirus. More than 100,000 people are currently hospitalized with COVID-19. In many places, in many states, the hospitals are out of staffed beds, which means that there are just not enough doctors and nurses to care for the people who are already sick with this disease, much less those that are going to flood into emergency rooms and intensive care units over the coming month. A lot of these patients are indeed old, as per the stereotype of a COVID-19 patient, but many are young. One of the people at UNMC told me that of late, with this current surge, all the trends have gone out the window. We have people from all kinds of demographics coming in and being severely ill. A lot of people are having to die alone. They're saying goodbye to their loved ones on an iPad, with nurses sitting with them so that they don't have to die by themselves. Some healthcare workers, in fact, many healthcare workers, have told me that COVID-19 patients are among the sickest people they have ever cared for. This is not the flu. These people require twice as much attention in an intensive care unit as a typical intensive care unit patient for 3 times the normal length of stay. They often need to be prone, that's flipped onto their stomachs at least once a day and then flipped back. A difficult procedure that can take several doctors and nurses. Sometimes they will have 8 to 12 different tubes running into their bodies, going directly into their hearts and major blood vessels. These tubes will be pumping in sedatives, anti-pain medications, antibiotics, drugs not necessarily for treating COVID, but for just keeping that patient alive. They will have a ventilator tube going into their airways, providing oxygen to lungs that cannot get enough on their own. This is an incredibly severe disease. People have talked about things like hospital beds, but hospital beds may as well be hotel beds if there are not enough staff to care for the patients in them. And that is the place that we have reached in many parts of the US, where there are simply not enough nurses, not enough doctors, not enough respiratory therapists to cope with this influx of patients. Reinforcements are very difficult to come by because the early surges of the pandemic were geographically localized. The first one hit the northeast, the second one was concentrated in the south. But in this third surge, the entire nation is on fire, and therefore it is very difficult to get help from other states that are less beleaguered, because everywhere is having to deal with a massive wave of patients. Reinforcements are not coming. And so healthcare workers are starting to burn out under the stress. Many of them have already had to deal with COVID-19 across the entire year and have had very little in the way of rest and recuperation, and are now entering the most difficult part of the pandemic, already exhausted, already worn out, already incredibly tired. They are scared about infecting their own families. They are scared about getting infected themselves on the job. We have already lost more than 1,000 healthcare workers to the disease, and that's not including the people who have been sick and are suffering long-term symptoms as a result of it. This pandemic is stretching our healthcare workforce to the extreme, to the very limits of what they're coping with, and their exhaustion is exacerbated by anger and by frustration, watching leaders, watching policymakers fail to enact the measures that would keep people safe and would keep hospitals from overflowing. A lot of the people I spoke to at UNMC have to endure 12-hour-long shifts in the hospital, watching streams of patients get sick and die, and then drive home past rows of full restaurants, full parking lots, bustling sports venues and bars and clubs, full of the very people who are going to be crowding into those hospitals in a couple of weeks' time. It is unsurprising then that people are breaking under the strain, that a lot of healthcare workers are going on strike. They didn't ask for these conditions, and though their job does involve helping people and saving lives, it is increasingly difficult to do that in a situation where people aren't doing their part. I have had emails after writing about the strain that healthcare workers are facing from people who endured the worst of the early surges in the earlier parts of the year, who can't face going back to an ICU now because they have been too traumatized by what they saw in their previous experiences. There is a silver lining, of course, which is that doctors are getting better at treating this disease. Over the course of the year, we've seen that fatality rates for people who have been hospitalized with COVID-19 have fallen. And that's not because of any wonder drug. The number of treatments that are available for people with COVID-19 are very, very few and far between. But it's simply because doctors are just getting better at understanding how to deal with this disease, which, to remind everyone, did not exist just over a year ago. But those gains are contingent on the knowledge and the savvy and the endurance of the healthcare workers who we depend upon. And as those people burn out, those gains will be eroded. This is happening right now, present tense, not future tense. We've seen that the percentage of cases admitted to hospital has declined in recent weeks, reflecting the full ICUs and emergency rooms that just can't cope with any more patients. We have seen that the case fatality rate has actually started increasing from its previous trough, reflecting the fact that people are unable to provide the quality of care that they used to be able to. As my colleagues Alexis Madrigal and Rob Meyer wrote just a couple of days ago, Americans are dying of COVID-19 who, had they gotten sick a month earlier, would have lived. On average, over the past week, 2,171 Americans have died from COVID every day, the highest that figure has been since the pandemic began. And it is, of course, not just COVID-19 that this tragedy applies to. While cities like New York and Boston have many big hospitals that can care for things like advanced strokes or failing hearts that need mechanical support, in Omaha, UNMC is it. If that hospital becomes full of COVID-19 patients and can't cope with other types of medical care, then there are entire categories of people with medical conditions who will simply not be able to receive the help that they need. Elective surgeries have already postponed. Patients with strokes and other urgent traumas aren't getting the normal level of attention because the pandemic is so all-consuming. And that's to say nothing of the tens of thousands, likely more, of people who get infected, don't go to a hospital because their cases aren't quote unquote severe enough, but who still nonetheless face debilitating symptoms that last for months. These long haulers already number in extreme quantities, and there are, I don't know, tens of thousands, hundreds of thousands of them from previous surges who are still coping with months and months of unrelenting symptoms that have debilitated them and have left many of them unable to carry out their jobs, carry out their normal lives. Their numbers too will swell as this third surge continues. All of these tragedies are all the more greater because there is finally some hope truly on the horizon. At least 3 vaccines have announced results from preliminary trials. They have been developed faster than anyone could really have hoped for. Experts I spoke to in March were saying that it would take 12 to 18 months to develop a vaccine. And here we are 9 months later with 3 so close to being approved. 2 of those at least are much more effective, at least in the context of results from these early trials, that anyone would have hoped for. We also know that we have an incoming administration that is going to take the problem seriously. Unlike the laissez-faire, lax attitude of the Trump administration, the incoming Biden-Harris administration does seem to have a actually detailed, workable plan to counter the pandemic. They have vowed to really try and actually control it. They have appointed people with expertise in medicine, in public health and infectious disease to their task force, to their transition teams, to important positions of power in the future government. All of this is a sign that come the end of January, we are going to be trying to deal with COVID-19 in a very different way, with newfound energy and commitment that has been lacking for much of this year. And yet, the near-term future is already set. We saw large numbers of people traveling around the country over Thanksgiving and are likely to see the same thing again over Christmas. People gathered in small indoor spaces without masks, talking with their families across multiple generations for long periods of time. These are all conditions in which the SARS-CoV-2 virus most easily transmits between people. And we've seen throughout the recent months that cases have skyrocketed for a number of different reasons, because people are not taking this pandemic seriously, because fatigue has worn in, because they are gathering in indoor spaces, in bars, in restaurants, in gyms, and because the virus is finding an incredibly easy time to finding new hosts. And so we're in a very weird position where the light at the end of the tunnel is brighter than ever, but the tunnel itself is darker than ever. This is the worst part of the pandemic, and it looks like it will get worse before it gets better. The next month is going to be very difficult, and our decisions now will affect how many Americans are still alive next year to receive the vaccines, and how many healthcare workers are broken in the process. In August, I wrote a cover story for The Atlantic asking, how could this happen? How could it have come to this? How could this country that was so highly rated in terms of preparedness have fallen so low? I'm going to offer you one non-answer and four actual ones. The non-answer is that it's not the virus. To begin, SARS-CoV-2 is not a once-in-a-lifetime pathogen. It is neither as lethal nor as contagious as others that we know of, or others that likely exist that we don't know of. It is not so contagious as to be uncontrollable. Several countries have now crushed a COVID-19 wave, and some have crushed two in the same time, as America has repeatedly floundered and failed to achieve anything other than an unenviable plateau. The US has never come close to bringing the pandemic to heel, and often it has not tried. And there are four reasons for that, and we can move through them. They go upwards in scale, from the local to the systemic. So failures, the first is a failure of local policy. So again, if we look at Nebraska, a couple of weeks ago, the governor once again refused to issue a statewide mask mandate, and promised to tighten restrictions once a quarter of the state's beds had filled with COVID-19 patients, but to a degree that was clearly going to be insufficient. If you look at Nebraska's COVID-19 plans, even the highest tiers still involved things like indoor dining, like open gyms, groups of people in 10 or so being able to gather in enclosed spaces. Again, exactly the kind of conditions that fuel easy spread of this disease. And the governor urged Nebraskans to avoid close contact, confined areas, and crowds. All sensible advice, but all nullified by his own policies. As one of the people from UNMC told me, people have the mistaken belief that if the government allows them to do something, then it is safe to do. And throughout the country, lax policies, early reopenings, a failure from state leaders to get ahead of the pandemic have repeatedly allowed people to find the risky situations that have spurred the continued spread of COVID-19. This isn't just a Nebraska issue, it happened across the entire US. Many states reopened too early, many states failed to get ahead of the virus. And this is because there is no sensible national strategy. There is still no coordinated attempt to deal with the pandemic in a way that transcends the states. America does obviously have this system of federalism where states do have a certain amount of autonomy to act independently. And this is in many ways a good thing. It means that state leaders can enact policies that should theoretically be more responsive to the needs of their communities. But that cannot be the only way of dealing with a pandemic, a crisis that affects the entire nation and indeed the entire world. States don't have the ability to spend at a deficit, and so only the federal government has the pockets and the power to coordinate the rollout of tests, the production of personal protective equipment, the actions that are needed at a national scale that will bring this pandemic to under control. This is not federalism working as it is meant to. This is a failure to deal with a crisis that needed national action. And so this is the second problem, failures of federal policy. A little under 4 years ago, on mid-December 2016, after the last election and before Trump's inauguration, I wrote a piece called How a Pandemic Will Play Out Under Trump. It was obvious then that some new disease would test the mettle of this incoming administration, as new diseases had tested the mettle of every recent administration. And I suggested that based on his previous actions, Donald Trump would rely on ineffective border controls, that he would tweet rashly, that he would spread misinformation and conspiracy theories, that he would ignore the experts at his disposal, like those at the CDC, and that he would exhibit reckless self-confidence. And well, those predictions have aged pretty well. I don't say this to evince any special prescience, but to say that Trump has always made clear who he is. His actions were predictable, not because I'm good at predicting stuff, but because his behavior as a citizen and a candidate made clear how he would react in a crisis such as this. His narcissism, his cruelty, his racism, and his rank ineptitude and laziness were clear to anyone who was watching the signs, even 4 years ago, before he became president. He is in many ways the worst leader we could have had at a time like this. And he has lied repeatedly to the American public, downplaying the pandemic even when he knew that it was serious. He staffed his administration with inexperienced neophytes and sycophants, giving them positions of power. He touted miracle drugs like hydroxychloroquine against all available evidence, blamed China and the WHO instead of coordinating an actual plan. Laughably, he called for less testing on the ridiculous logic that that was the cause of the cases that we were seeing, rather than indeed the spreading virus. He silenced and diminished the CDC, perhaps once the most respected public health agency in the world, and now a shadow of its former self, being forced to rebuild its reputation at a time when it was needed the most. And perhaps most bizarrely, unlike many of the people who have actually been on the receiving end of COVID-19, Trump utterly failed to learn from his personal bout with the virus. Instead, he trumpeted his own strength, suggesting that he beat SARS-CoV-2 because of some personal fortitude. By fortitude, of course, he really means immense privilege, the privilege of being able to get airlifted to a hospital, to get pumped full of no less than 3 state-of-the-art treatments that almost no other person could access together, to receive round-the-clock medical care, and then to have the utter gall to tell everyone else that they should not let the virus dominate their lives. In this, Trump is very much like America as a whole, and really symbolizes the third great failing of the nation this year. America failed at COVID-19, not just because of Donald Trump, but because it had a multitude of different weaknesses going back years, decades, even centuries. Donald Trump was not the cause of America's pandemic failure. In many ways, he was as much a symptom of it, a sign of all the weaknesses and vulnerabilities that have plagued the nation's history. America excels at mistaking privilege for fortitude, for example, and therefore conversely at blaming individuals for societal failures. When outbreaks happen because college students partied, as college students are wont to do, university administrators blamed them for being selfish, but said nothing about their own irresponsible choices in opening up the environments in which selfish choices were all but guaranteed. When it became clear that people of color, people in Black, Latino, Indigenous, Pacific Islander communities were disproportionately being infected and killed by COVID-19. Some people started talking about biological differences or the large number of chronic illnesses. Again, everything became a matter of individual risk and responsibility, without thinking about the centuries and decades of discrimination and systemic racism and inequity that have made communities like that more vulnerable to not only COVID-19, but a host of other health problems. America has a cavalcade of pre-existing vulnerabilities that made it rife that were easily exploited by a rapidly spreading virus. It had overstuffed prisons, understaffed nursing homes, poorly vented buildings that created the perfect conditions for super spreading events. It had a public health system that had been chronically underfunded and thus left with insufficient people to do basic things like contact tracing that even much poorer countries could easily mobilize. It had a fragile healthcare system that depends on just-in-time stocks and convoluted supply chains for things like personal protective equipment and essential drugs, and that left healthcare workers unprotected at the start of this pandemic and have left them with a shortage of reinforcements right now in the third surge. It has a bizarre system of employer-linked health insurance that has long left poor people without access to healthcare, and that is especially devastating in a pandemic that has wrecked the economy and the healthcare system alike. It has spent years shredding social safety nets, which mean that poor and marginalized communities can't take care of themselves in an emergency like this, and has left essential workers who are working hourly wages without paid sick leave, unable to take the actions that many of the rest of us have been able to take to keep themselves safe, to stay at home, to avoid infecting those around them. We have long neglected the mental health of citizens and healthcare workers, problems that are going to come a cropper over the next year as the continuing mental health consequences of this current surge and of these long periods of social isolation manifest. We have long dismissed chronic illnesses like myalgic encephalomyelitis, dysautonomia, and many others. Viruses illnesses, many of which are tied to the long-term effects of viral infections. And the result of this dismissal means that now, when many COVID patients have developed similar long-haul patients, doctors have had very little to offer them, save for yet more dismissal. We have long ignored the problems of social media platforms that run on algorithms that prize engagement over truth and that essentially act as radicalization engines, serving people with ever more extreme content, regardless of whether such content is true or not. Those same platforms have spread misinformation during the pandemic faster than it could be debunked, and are likely to be the source of more misinformation as we move into the vaccine era. None of this was a secret. None of these problems had gone undiscussed, but they were part of the world that we had normalized to, much like police brutality or school shootings, inequality in access to healthcare, systemic racism and sexism and ableism. These were just, these were yet more unacceptable things that America had come to accept. And throughout the pandemic, people have asked how we can go back to normal without grappling with the fact that normal led to this. That the world that we have built and become accustomed to was a world that was especially prone to a pandemic and especially unable to cope with it. COVID-19 has exposed many of these problems and should hopefully be a wake-up call. Hopefully, in theory, we learn from experience, we see what went wrong, and we can make different decisions next time. There will be a next time. More pandemics are on the horizon. Those of us lucky enough to get past this one will almost certainly have to deal with new emerging diseases in the future. And will we learn from that? I don't know, but I think the fourth problem this year leaves some doubt about that we are trapped in these failures of intuition that have left us making the same mistakes over and over again. I've written about these failures of intuition, and I think given the time constraints, I'm not going to go over all of them. But if you look at the Atlantic, at the piece about how America is trapped in a pandemic spiral, you will find a list of nine errors of thought that we keep on making. Some of these I've already talked about, a tendency to personally blame people rather than looking at the systemic errors that have made certain groups more vulnerable to this virus. But I can talk about a few others right now. There's the serial monogamy of solutions. So we keep on bouncing from one potential solution to another without putting them all in play at the same time. So things like testing, contact tracing, masks, safe solutions for quarantining and isolation. We need all of these together to make a difference with the pandemic. None of them can do the job on its own. And yet we just bounce from one to the other without ever fully putting any of them into play. And we wonder why things are still not in control. And this is a lesson that we are going to need to learn before we start rolling out a vaccine. Even a vaccine, the most important part of the end game is not going to do the job on its own, and especially at a time when it's going to be deployed and before the country reaches a herd immunity threshold, it is still going to be absolutely important to do all those other aspects of public health, to continue to test people, to roll out testing in a way that has not been done this year, to continue wearing masks, to continue wearing physical distancing, even for people who have already received the vaccine. This is going to be a long road to getting back to normalcy, and it's going to be a disaster if vaccines get approved and they start getting used and everyone drops all the other guards that have not really even been fully put into place earlier this year. We also need to stop thinking about false dichotomies, a problem that has plagued us over the entire year. In March, we created this false binary between lockdown and doing absolutely nothing, between everyone staying indoors and everyone going about their normal lives. And of course, this is preposterous. There's plenty of middle ground solutions on offer. And yet by creating this dichotomy between lockdowns and business as usual, we put all those other middle ground solutions to the side, and we create this false choice. Similarly, we create a false choice between saving lives or saving the economy, which was always ridiculous. You cannot restore the economy while the virus is still raging. You need to control the pandemic in order to give, to create any hope of an economic rebound. More and more, these problems have plagued us over the entirety of the year, and they are still going to be a problem as we move forward into the next phase. One of the issues that has long been a problem and is very relevant to us right now in the holiday season is that there is a reactive rut, that there is a data lag between the consequences of our risky actions and between our risky actions and the consequences becoming clear in national and local level statistics. So it takes several days for people going out and about and getting infected to develop symptoms. More days then for those symptoms to warrant a test, and for those tests results to come back, for those people to become sick enough to warrant a hospitalization, for people in hospitals then to become severe enough to need an ICU, for people in the ICU to then die. This means that there is about a 12-day lag between cases rising and hospitalizations rising, and a 22-day lag between cases rising and deaths rising. And that means that at the point when you start realizing, because of spiking graphs and news stories, that the pandemic is once again becoming bad, it is too late to avert the near-term disasters that are about to unfold. COVID-19 data is much like the light from distant stars. It always reflects the past rather than the present. And so we need to get out ahead of the virus. Now, obviously, the vaccine is going to help with that. But as I said, that is going to be a slow and gradual process, during which we cannot expect a rapid return to normal. That desire for normalcy is one of the intuitive errors that I wrote about in my pandemic spiral piece. And if we succumb to it too quickly, we are going to enter even further problems that are going to negate many of the benefits that a vaccine could bring us in the early half of 2021. There is hope, but we need to hold the line this year. And we need to understand that even as we enter the era of vaccination and an era where COVID-19 becomes less of a problem than it has been in 2020, that we cannot just go back to normal, that normal led to this. And that if we are to avert future epidemics and pandemics and do better the next time round, that we need to fix many of those underlying problems. We cannot just assume that a Biden administration or a COVID-19 vaccine is going to act as a remedy that stops us from dealing with the same kinds of issues this year as that we will the next time a new virus threatens us. The pandemic has brought out some of the worst in humanity: opportunism, selfishness, a catastrophic lack of empathy. But it has brought out some of the best too. It shows us we cannot do this alone, that we have to protect each other. It shows us what is at stake and what weaknesses we have endured and found acceptable, and that we should no longer accept. I'm going to end this talk with the words that I used to end my Atlantic cover story. The pandemic has been both tragedy and teacher. Its very etymology offers a clue about what is at stake and the greatest challenges of the future and what is needed to address them. Pandemic, pan and demos, all people. I hope we learned that lesson for the next year and for all the years to come. Thank you very much.
Hi. Thank you, Ed, so much for sharing your insights and being here as part of our online public programs. We truly appreciate you taking the time to talk to us tonight. Your prolific reporting throughout this year has really helped so many understand where we are and how we got here. And I know our audience is really eager to ask questions based on what they've heard tonight and may have read previously from your work. For our audience members, as a reminder to please place your questions in the Q&A section of Zoom, as we're only taking questions there. I'll start us off with some questions while you all enter yours. As President Sparks mentioned, I'm a chemical engineering professor here at Cooper Union, and since my research is focused on drug delivery, I of course have been paying close attention to the vaccine development. I feel remiss if I didn't start our conversation there. So you've spent many years interviewing experts across a multitude of fields, such as Akiko Iwasaki, an immunologist at Yale, or Natalie Dean, a biostatistician at the University of Florida. I was wondering, based on your conversations with so many leaders of the field, how do you see 2020 playing out with the viable vaccines almost weeks away? Do you have a perspective on the timeline of events? Will it be a broad and rapid rollout of the vaccine?
Do you mean the end of 2020 or 2021?
Oh, sorry, 2021.
Okay, so I'm actually working on a piece that will sort of look at that. That will hopefully come out at the end of the year. So looking at what 2021 is going to bring. In terms of the vaccine, I'm still sort of in the middle of reporting that. I do think that it is going to take some time. Right. Everyone is very clear that we should not, you shouldn't expect the entire country to be vaccinated within the first couple of months. It's going to take probably half a year, optimistically, and maybe even longer. This is the most complicated vaccination program that we have ever had to try and do. Just in terms of its scope, in terms of the number of vaccines that are going to be part of it, in terms of vaccinating a huge proportion of the population and not just children, for example, the fact that it is all happening in the middle of a pandemic. Like, think about the fact that we have been dealing with this for like almost a full year now. And the very people who are going to be responsible for getting this vaccine into people's arms are the same people who are exhausted and worn out from this year of incredibly intense work. The logistics are unenviable. Like, you're having to distribute them across the country. You need to allocate them fairly and equitably and efficiently. There are issues with how cold the vaccines need to be. At least one of them needs to be shipped in dry ice. There are issues with getting the vaccines to people in rural and remote communities, many of which are being incredibly hit incredibly hard right now by the third surge. And there are issues with vaccine refusal, with with misinformation, with conspiracy theories, and indeed with very reasonable skepticism about vaccines from communities, from like many minority communities that have long been mistreated and neglected by the healthcare system. There's a huge amount of mistrust there, and some of it is very reasonable and is going to be difficult to undo very quickly. So I just want to make clear to everyone that, having vaccines is great, and getting to this point where we have vaccines that are likely to be improved so much quicker than anyone expected, and that seem to, at least in the context of clinical trials, be very effective, is a truly monumental achievement. But there is a massive difference between vaccines and vaccination, and that the latter is what we're going to need, and the latter is going to be very difficult to do.
On another topic that I was actually really interested in after reading your work is that you repeatedly report on that marginalized long hauler demographic. I was curious, what were your view of that in the lens of the cost of care and disparities in privilege, and for how those who can afford better healthcare or healthcare at all, how this will play out for them in the coming years, for those who don't have the healthcare to have long-term coverage?
Yeah, it's a huge problem, and the disparity there goes beyond the usual ones we're used to thinking about, where poorer people are less likely, and people from a lot of minority groups are less likely to be to have insurance and access to healthcare. With the long hauler community, even people who actually have insurance are still struggling. Like, a lot of long haulers got infected in the early parts of the pandemic, in months like March or April, when tests were very rare, were very scarce. A lot of them were only tested maybe months after they first started developing symptoms, when the tests are vanishingly unlikely to actually be positive, because these people are unlikely to still have replicating virus, but are still dealing with the symptoms, with the fallout from their infections. So a lot of them don't have positive tests. They don't have the surety of a COVID diagnosis. Now, they've talked to healthcare providers who've assured them that what they've had is COVID, and it is very clear from a lot of the studies that the pattern of symptoms of people who have received negative tests is exactly the same as those who've got positive ones. So it's pretty clear that they've had COVID-19, or at least the majority of them do, but they don't have that confirmation that they need to access disability benefits, to make use of medical insurance. And that is a huge problem. We are going to face a large number of people who are going to be suffering from long-term disability from this, but who are unable to access benefits that are already, on a good day, very difficult for most Americans to access. And I think that is going to be an issue going into 2021 that this country is nowhere near ready to deal with. Like, even at a point when when vaccines start rolling out and we start returning to some semblance of normalcy, for a lot of people who are infected with COVID-19 this year, normalcy is not going to be a part of their lives.
Thank you. Another sort of theme question that we're seeing in the Q&A is, how do you communicate or convince people to actually get the vaccine, even though if it's offered?
Yeah, it's very difficult, right? So, okay, it depends on who you're talking to, right? So everyone has in their mind this idea of who an anti-vaxxer is. And I think for people who are very hardline in those communities and who are very bought into conspiracy theories, it's very difficult to reach them, right? The one thing we absolutely know is clear is that facts don't change people's feelings. You're not going to information your way out of this. You're not going to do some myth-busting blog post, or everyone looks for information to counter the misinformation that they've heard, and it's often not the right strategy. It doesn't work. to change people's minds, you often need to engage in a very, very personal and very focused way. You need to understand the beliefs and the values that have informed people's reluctance. Like, is it because they are skeptical of government, of the pharmaceutical industry? Is it because they are worried about their children or their loved ones? Is it because, as I've said, that some communities actually have a very legitimate distrust of the medical establishment? Understanding all of these problems gives you ideas about how to reach people. And it's not about lecturing them. It's not about contradicting misinformation. Often it's about finding shared values, shared points of commonality, trying to bridge people who might have very different beliefs than you do. And I think that's how you change people's minds, but it's very difficult. I think one other thing that we can do right now is to have a think about pre-bunking approaches. So thinking about the kinds of misinformation that are going to abound as vaccines start rolling out, and getting ahead of them, trying to get people to understand the kinds of things that they are likely to see from people who are actively trying to sow misinformation around vaccines. So one very obvious example: if you vaccinate a huge proportion of the country, then you are almost certain to get conditions that were going to happen anyway and have nothing to do with the vaccine happen immediately after the vaccine. So you will get people who get vaccinated and immediately get heart attacks, or people who get vaccinated and immediately get strokes. And those things were going to happen anyway, but they happen in the aftermath of a vaccine. And if we deal with those stories wrongly, either by brushing them under the carpet and ignoring them, or by drawing some false connection between them, then we're going to run into problems. And I think these are the sorts of things that we need to be thinking about right now, before the vaccines start rolling out, so we can get ahead of the game.
I think on the other hand, too, when you have half the population, I feel believes that the vaccine is going to be some sort of magic panacea for us. I feel like the public thinks that this might offer more like sterilizing immunity, where people will be able to fight off of the virus before it even takes hold, versus what's more common and likely in this scenario, which is common for respiratory virus, which will be the functional immunity. And so people will think that they won't be able to pass the virus because they're immune, but they are still capable in that scenario. And do you think that is going to play out in how we, treat 2021?
Yeah, and I think we need to be very clear on this, right? Like, so we still don't know. We know that that these vaccines, that certainly the Pfizer and Moderna vaccines seem to be good at preventing severe disease or symptomatic disease, right? So they're good at preventing COVID-19. What we don't know is whether they're good at preventing infections in the first place, or whether, or indeed for preventing people from transmitting the virus. Now, I think it's reasonable to suggest that maybe they will have some sort of effect on that, but we don't know, right? We need actual data on that. And I think we need to be very clear in the messaging around this over the next sort of couple of months or so. Like, a lot of this comes down to how we talk about these vaccines, how we talk about what they can or cannot do. And this is why I've saying now in this talk and elsewhere that we need to understand that the vaccine is not just a light switch, right? Like, it's not just we approve vaccines and immediately go back to a 2019 scenario where everyone is going back out to bars and restaurants. And, in this phase where immunity is building up in a population, if you have a vaccine that has less than perfect protection, which they will do, and that doesn't entirely prevent transmissions, then yeah, absolutely, you can get a situation where people get a vaccine but aren't fully protected, might still be capable of spreading the virus, and where we still need public health measures, we still need masks, still need social distancing. I think that hopefully next year we start getting back into a situation where we get more of our lives, we get to see people again, where we get to have more of a social experience than we've had this year. But a lot of that is contingent on us continuing to hold this line even as we roll into this vaccine era.
Another audience question we had is it fair to argue Western society's focus on the individual are less suited for dealing with the pandemic?
I think a lot has been said about this idea of like individualism versus collectivism. I think you can you can do any number of differences between countries that have and have not dealt well with this. And I'm loath to pick any particular one. I think, yes, you could argue that a focus on the individual doesn't lend itself to the kind of public health measures that we need that we have needed this year. I mean, things like masks, physical and social distancing, these are actions that we take at individual inconvenience for the public good. And there's a stereotype about the American public that because they are so heavily individualist, they'd be less likely to do these kinds of collectivist actions. But I think that's actually in the main not true. Like, America has been remarkably supportive of these measures and remarkably willing to take them up. Very contrary to that stereotype of a super individualist nation that only thinks of where people are only thinking about themselves. And yet there's only so much you can do in a situation where leaders are putting in lax, policies that aren't evidence-based, where they aren't when they aren't holding up their end of the bargain. In many ways, this year is a story of American individuals actually doing their part, but American society and American government not doing their part, like sort of leaving it to individuals to sort of bootstrap their way out of this incredible crisis. And that shouldn't have to be the way it is. It shouldn't have to fall down entirely on people to do this on their own, or to even do it collectively on their own. This is why we need social safety nets. This is why we need a strong and resilient public health infrastructure. Like, all of those things, have been eroded over the last decades, and hopefully we are going to rebuild them in the future. I think one thing I will say about this in the context of the vaccine, the fact that we have so focused on a vaccine throughout this year and certainly now, it reflects the fact that we have this very biomedical, solutions-based approach to health. That a problem arises and we look to technology to get us out of it. And America's been very successful at doing that. And the Western world arguably has been very successful at doing that. And what that means is we plaster over all of the social problems that I've talked about that are actually, that are significantly responsible for the spread of disease. And people didn't always think this way. I have a piece coming out in which I argue that in the mid-19th century, folks were arguing that medicine is a social science. That diseases and epidemics spread because of things like poverty, lack of education, lack of sanitation. We see those things in 2020 in the context of the COVID-19 pandemic. And yet, instead of doing the social interventions that we know could make a difference, things like paid sick leave, hazard pay, better access to healthcare, we instead turn to drugs and vaccines, as we always do. That cannot be our only approach. Like, if that is the lesson that we take away from this, if we get to a point where hopefully, enough people are vaccinated to reach a herd immunity threshold, if what we learn is, well, that was great, we got a vaccine out in record time, beat the pandemic, excellent. We have learned the wrong lesson, and we are going to be facing this problem again.
We have another audience question from Joanna Smith, who asked, since many in the US seem to care only about the economy and money, do you know anyone who has quantified the total cost of medical care and lives lost and price per life of the pandemic so far?
I am pretty sure that people have done those calculations, and certainly there are lots of figures that are thrown out about the cost of pandemics in general. I do not have those numbers off the top of my head, unfortunately. I mean, what I can say is that this is a thing that, like, everyone who's talked about pandemics and public health has argued for years and decades. I wrote about this in my 2018 piece. Bill Gates has argued about it. Everyone with an understanding of this field has talked about exactly this point, which is that prevention is incredibly cost effective it is so, so cheap compared to the cost of dealing with a pandemic, either in terms of healthcare or in terms of the massive economic fallout. You're always better off investing in public health and in prevention ahead of time. And we don't. And we don't because when prevention and public health are successful, ironically, they make the case for their own diminishment. Because you don't see the lives that were saved. You don't see the crises that were averted. You don't see the people who didn't end up in hospital gasping for air on a ventilator. All you see is a bunch of people going about their normal, healthy, lovely days. And we all take that for granted. Even now in the COVID-19 pandemic, when we after the spring, when people made the decision to stay at home, to physically distance themselves, to take the actions that were necessary for curbing the first surge, immediately afterwards, pundits were arguing that the fact that hospitals were not overwhelmed was a clear sign that everyone was overreacting, which is daft. That is entirely the wrong lesson. And yet that is the lesson that we always take away from an averted crisis. We always say overreaction. And this is why public health has been underfunded for so long. This is why we don't put in the absolute pittance that it would take to shore up a strong and resilient public health infrastructure that would leave us better prepared to not have to deal with a massive economic recession the next time a pandemic hits.
I also have another question from Paul McDougall, who is a question I'm interested in because he is also a bioengineer, and something I'm curious. Do you think the pandemic will spur on greater academic interest for young people to study virology, microbiology, and other sciences that are related?
I hope so. I wrote a piece in March called How the Pandemic Will End, and I've got a sort of throwaway line in there about like Generation C, which is what I'm calling people who grew up in the COVID era, like Gen C kids writing essays at school about wanting to be epidemiologists, and they grow up. Like everyone knows what an epidemiologist is now. Tony Fauci is a household name in a way he wasn't like last year. I do hope that it will spur research interest in these fields. I think that people, until a year ago, there were maybe a few dozen labs that focused on coronaviruses. People who've studied these viruses have told me that they had to work very hard to explain to people why they worked on coronaviruses, and that is absolutely never going to be a problem again. That being said, I think our memories are short, surprisingly so sometimes. Research in these fields also peaked after SARS and MERS and fell again. So is this going to lead to a sustained interest in these fields? I don't know. I would also argue again that the pandemic reveals that pandemics, and in fact the great problems of our time, biodiversity crises, food and water shortages, climate change above all else, are systemic problems that touch on every aspect of society. And pandemics are not just a science problem, as is abundantly clear this year. They are an economic problem. They're a problem about our communication infrastructure. There are problems about the carceral state, the healthcare system, our education system. Every aspect of society goes into whether we are prepared or not. And part of the problem with preparedness is that we haven't adequately thought about all of those things and how well they interact. So, I know that Cooper looks at both science and the arts, and I think that's crucial. Like, I throughout this year have tried to report on the pandemic, not just talking to virologists, epidemiologists, but talking to social scientists, sociologists, anthropologists, historians, linguists. All of these perspectives are necessary to understand what is at stake and how to deal with a problem like a pandemic. And I hope that it's not just people who will take up an interest in science. I hope that scientists will also understand the values of social science and the arts and the humanities, and really foster much more of a it's almost cliche to say interdisciplinary attitude to scholarship. But I think that's what we need to deal with these omni crises.
I have one last question before we go, and I actually wanted to ask it more about your writing process. So you spent the better part of a year working on that 2018 Atlantic feature on whether the US would be ready for a pandemic. And now you write almost weekly in what seems like your own version of Operation Warp Speed, while in the midst of a worldwide crisis that's reliant on data that's not available in real time.
Yeah.
What have you learned and potentially changed in your reporting style, given the speed COVID-19 reporting requires?
You know, to an extent, I've been training for this my entire career. You know, I write fast, I report fast, I learn, I know how to enter areas that I don't, you know, previously didn't know much about, find the right experts, talk to them quickly, you know, learn about areas that I'm not an expert in, synthesize huge bodies of knowledge and do that at speed. And that's been invaluable this year. You know, I've written, I think, 20 features now on COVID-19 in the space of 10 months. They range between 2,000 and 8,000 words. I don't know. I don't know what to say about how to do that. Other than that, I am also very tired and exhausted and very much need a break. But you know, this has been some of the most important work of my life. And, you know, I feel very privileged to be able to be of service to the world at this very crucial time. You know, I think training as a science journalist for many years before this was invaluable. Being part of the Atlantic and an environment that allowed me to the space and the time and gave me the mandate to take these big swings was invaluable. You know, a lot of journalists work in places that won't allow them to say, I'm just going to take 2 weeks to work on this one piece and it's going to be great, but you're going to need to not pester me during that time. Work like this doesn't happen without that kind of institutional and editorial support. And, you know, I've said in this talk that many of America's pandemic failures are systemic, right? It's not just individuals making bad choices, it's entire systems that push them towards bad choices. Well, the same thing must be said about our successes. I get to do meaningful and important work because I found myself working with colleagues who support that work and in an environment that allows me the chance to do that work. You know, and I would hope that that is a lesson that journalism takes from this, that if we want good writing and solid science writing in a moment of crisis like this, you need to give people the space and the environment in which they can do that work.
Just a short follow-up. Do you actually feel like you have COVID fatigue just writing solely about the pandemic? Do you actually miss writing about other scientific topics like putting 3D glasses on cuttlefish or shedding light on the extinction of giraffes?
Very much so. I'm actually going to, so I was in the middle of book leave when I had to write about this, but I am going back for a few months in January just because I need to, like, it is a lot, and my mental health is tattered right now. It is very difficult to write about a crisis like this, which is so ongoing, where the stakes are so high, where tragedy is everywhere. You know, these last pieces about healthcare workers and what they've had to go through this entire year and these months in particular have been very, very draining. It is very difficult to take all of that in, process that, try and make sense of it for people at a time when so much is unclear. You know, I've written before that writing about the pandemic is like being gaslit on a daily basis by everyone from some random person on Twitter to the president of the United States. It really is like staring into the sun constantly without blinking for months on end. And I do need a break. But, you know, like I said, this is not going to be a problem that goes away immediately at the start of next year. So, you know, I'm looking forward to seeing how things are in the spring and to pick up the good work at that point. And in the meantime, I've still got like 2 big pieces to finish and to come out before the end of the year.
Well, thank you again. I think I can echo our audience for all you've done in reporting for this year on the pandemic.
Thank you.
It's been incredibly thoughtful and informative discussion we've had today. And thank you for delivering the John J. Iselin Memorial Lecture. We hope that one day you'll be able to join us here in person at the Great Hall in New York City's East Village. And thank you to all our attendees tonight. If you like this Cooper Union program, please come back and join us, whether online through Zoom, as we are now, or eventually in person once again, fingers crossed. Our programs are free and open to the public, and you can find all of them on the events and exhibition page on cooper.edu. Have a good night.
Thank you.